This program is brought to you by Emory University.
Good morning, everyone. Happy Friday. Thank you for joining us for Fellows Conference. Today we have Martin Campbell, who is one of our second year fellows on the clinical track. Martin was an Emory resident and a chief resident, and then we were lucky enough to keep him here for fellowship, and he will be joining our 2 and 2 EP, well, the EP part of the 2 and 2 EP program starting next summer. Martin, it's all you.
Awesome. Thank you so much for that lovely introduction, Dr. Coley. Once again, my name is Martin Campbell. Thank you all for joining me today, taking time out of your day. The title of my presentation is Cardiovascular Health in People Living with HIV, Strategies for Risk Reduction and Optimal Care. I thought this was a pretty cool topic because even though we live in Atlanta, Georgia, where there are high rates of HIV, and even though we practice at Grady, where we see a lot of HIV patients with cardiovascular disease, I haven't really heard that much about, focusing our care and tailoring our care for the treatment of cardiovascular disease in this particular population. I have no financial disclosures. And so our learning objectives for today are the following. So I need you to be able to describe the epidemiology and pathophysiology of cardiovascular disease in HIV patients, including the roles of chronic inflammation, immune activation, and antiretroviral therapy. You should also be able to incorporate the AHA guidelines to assess, prevent, and manage cardiovascular risk in HIV positive patients, and also incorporating risk enhancers, traditional risk factors, and ART-related metabolic effects. And lastly, I would like for you to be able to recognize and address the specific clinical challenges in this HIV positive population. So I always like to start off with a good case. I'm going to require you all to kind of be a little bit interactive and put your answers in the chat. So we got the first case here. So let's say you're in clinic. You have a 55-year-old man with HIV on long-term integrase inhibitor therapy. His blood pressure is 135/85. His LDL is 130. His BMI is 28. He used to smoke, but he quit a year ago, and his father died of a heart attack at age 58. So the question is, which is the next best step to manage his cardiovascular disease risk? Is it A, to start moderate intensity statin immediately and considering coronary artery calcium score and reinforcing lifestyle interventions? Is it B, not worrying about a statin at all right now, but rather reassessing in 1 to 2 years because his LDL is less than 140? C, switching to a protease inhibitor-based ART to improve his lipid profile, or D, recommending aspirin for primary prevention instead of a statin. Now, I'm going to give you maybe about 60 seconds or so to just type your answer in the chat, and I'll record that, and then we can talk about it later if that's okay.
I'm looking at the chat here. We have a couple of A's, lots of A's. We have a question mark C.
Okay, I like it.
I think the answers have slowed down. So if you want to,
Sure.
yeah.
Okay, so it seems like the majority of you picked A. Maybe there's some question about C, but that's cool because we'll talk about that later. So we got case number 2 now. So you have a 50-year-old woman who has HIV. She's on a protease inhibitor-based regimen, and she had a recent NSTEMI. Her LDL is 155, her blood pressure is 130/78, and her A1C is in a pre-diabetic range. Question is, which lipid lowering strategy is safest and guideline aligned? Is it A, high intensity atorvastatin, regardless of protease inhibitor interaction? Is it B, high intensity pravastatin or pitavastatin with monitoring? Is it C, ezetimibe monotherapy to avoid the interactions with statins? Or is it D, switching her ART to an integrase inhibitor based therapy and then starting simvastatin afterwards? Same thing. I'll give you about 30 or 40 seconds to drop your answer in the chat. Okay. Let's see what answers we have. Looks like we have, oh, this one's different. It doesn't seem like there's a common answer that everybody is picking. Okay, so that means that was a well-written question. Bravo to me. Fantastic. Okay, so we have some things that I can actually teach you, being that you don't have all the answers already. So that's good. Okay, now we got one more case I'd like to bother you with. So this one, you have a 57-year-old man with HIV who is virally suppressed, and he presents with exertional chest pain. He had a recent left heart cath with clean coronaries. His EF is 60%, and he has some mild LV diastolic dysfunction. His LDL is 135, his blood pressure is 130/82. What are you gonna do? What is the most evidence-based interpretation of the source of his chest pain, and what is the best next step? So is it A, likely microvascular ischemia? You want to optimize his risk factors and consider starting a statin. Is it B, because he had normal coronaries, no treatment is necessary? Is it C, you want to switch his ART to a protease inhibitor-based regimen for vascular protection? Or D, starting a long-term dual antiplatelet therapy? I'll give you guys another 30 seconds. All right, I see some answers pouring in. Let's see what we got. So I see a lot of people saying A. Okay. All right. So there's no real disagreement there. Okay, so we'll talk about that later. Fantastic. Well, thank you all for participating in that. Now we're going to really kind of get into the meat of this. I'm hoping that these questions kind of give you a clue as into what we're going to be talking about today. All right. So next, what I really want to discuss is the significance of cardiovascular disease in the HIV population. As antiretroviral therapy has become highly effective and widely used, HIV infection has largely shifted from a fatal disease to a more chronic, manageable one. And as a result, people living with HIV are living longer. However, cardiovascular disease has emerged as a major comorbidity. According to the AHA scientific statement on the characteristics, prevention, and management of cardiovascular disease in people living with HIV, the relative risk of manifestations such as myocardial infarction, heart failure, stroke, and other cardiovascular disease is roughly 1.5 to 2 times higher in the HIV population compared with those who are non-infected. And that's even among those with viral suppression. Given duration of survival and aging, the absolute burden of cardiovascular disease in the HIV population is rising substantially. And therefore, cardiovascular disease in HIV is not a niche issue. It's a core present clinical challenge that we should be paying attention to. If you look here, we have a nice figure from that same AHA statement article highlighting these very points. As we look along the x-axis, we see time plotted but divided into 3 eras. The pre-ART era that preceded the year 1996, where we didn't have as much widely used antiretrovirals. This era was hallmarked by uncontrolled HIV, AIDS-related complications, and AIDS cardiomyopathy. Then you have the early ART era from 1996 to about the year 2007, which was hallmarked by our earlier ART treatments, often protease inhibitor based, which led to side effects like dyslipidemia and atherothrombotic disease. Then to the far right, we have the modern ART era, which started around 2008 and beyond, which we had better drugs, right? We had NRTIs, NNRTIs, and integrase inhibitors. And there was also a government policy change in the United States in 2015, where there was an aggressive push to pretty much getting everyone with HIV on ARVs. As time progressed and the antiretroviral medications improved, we see that the relative risk of heart failure in persons living with HIV compared to the general population actually decreased. But because the people living with HIV are living longer, we see the overall prevalence of myocardial infarction and heart failure among these patients increase over the years. As people living with HIV began living long enough to see the manifestations of cardiovascular disease, we noted that the HIV population have a higher risk of developing atherosclerotic cardiovascular disease than non-infected individuals. What we see here is data from a meta-analysis published in Circulation in 2018 that included 17 different retrospective cohort studies published between the years 1997 and 2015 that looked at the rates of cardiovascular disease, particularly stroke, myocardial infarction, and cardiovascular events in patients living with HIV versus non-infected individuals. And what they found is that persons living with HIV have about a 2 times greater risk of developing cardiovascular disease than the general population. The point of this slide is to highlight the significance of cardiovascular disease and HIV in a now considered higher risk population. So for those of you who will argue that, yeah, Martin, the risks of cardiovascular disease in HIV patients were shown to be higher. However, these were mostly observed in older studies back when protease inhibitors and other ARBs that increase metabolic risks were more prevalent. I'd like to show you some more recent studies from the modern art era that still highlight the increased risk of cardiovascular disease, particularly atherosclerotic cardiovascular disease in HIV patients. This is a recent study published in the Journal of Infectious Diseases in 2022 that came out of the UK, where they did a population-based matched cohort study that included 9,000 patients living with HIV, and they matched them with 36,000 HIV negative patients, and they followed these patients for 20 years. What they found was that the incidence rate, if you look over here, what they found was that the incidence rate of cardiovascular disease was significantly higher in HIV patients with a hazard ratio of about 1.5. And this relationship held true even when they adjusted for things like sex, smoking history, BMI, and ethnicity. This was a major finding, as this was a very large study done in a country that generally has lower rates of cardiovascular disease than what we see in the United States. And it was studied during the modern art era, where we primarily use integrase inhibitors, which have less metabolic consequences than the protease inhibitors used in the early art era. Another study published in Hypertension Journal of the AHA in 2023 was a very large cohort study that matched 109,000 individuals living with HIV in a 1-to-4 fashion, with a total of over 400,000 non-HIV infected individuals who all had hypertension. And they looked at incidence of cardiovascular disease between the two groups. They mostly used data from the Market Scan database, which is like a health insurance database in the United States for US adults. And ultimately, what they found was that in folks with hypertension, the presence of acute myocardial infarction was significantly higher in those who had HIV compared to those who didn't. Understanding that the result was primarily driven by men living with HIV and also those who were less than, who were younger than 55. I think this particular slide highlights the importance of early cardiovascular disease in the HIV population. So even though we now know that there's higher risk of cardiovascular disease in persons living with HIV, and that acute myocardial infarction is higher in men with HIV, particularly at younger age, that doesn't mean that the pathophysiology of coronary plaque development is the exact same between those infected with HIV and those who aren't. In fact, it has been shown that in men with HIV, there is a greater prevalence of non-calcified plaque. We know this because of the multi-center AIDS cohort study, also known as the MAC study, where researchers found that among men with a coronary artery calcium score of 0, people living with HIV had a significantly higher prevalence of soft plaque compared to HIV negative men. Then later, what this article is highlighting here, they did a subgroup analysis of that study and showed that plaque progression was particularly higher in men with higher HIV viremia. So if you look at the data here, you look in the purple bars, those represent those who are HIV positive and viremic. And the data in the blue bars represent those who are HIV positive and who were suppressed as compared to the HIV negative folks. And as you can see, there was a significantly higher amount of plaque progression in those who were HIV positive and viremic. I think these studies were important because it highlighted that the pathophysiology of plaque development in HIV population is probably a little more complex than previously understood. And it also highlights the significance of ART initiation and adherence in lowering the risk of ASCVD progression. Taken together, this may actually suggest that the traditional methods we use for predicting ASCVD risk in HIV patients may not be as reliable as we once thought. All right, so given the fact that ASCVD risk tends to be higher in the HIV population and that the pathophysiology may be slightly more complex than in non-infected individuals, the next question is, are our current traditional ASCVD risk calculators enough to predict outcomes in this high-risk population? The short answer is no. This has been studied extensively over the years, actually. So I decided to share here this meta-analysis of 9 different observational studies totaling 75,000 HIV patients that evaluated 10 different cardiovascular disease risk prediction models for their accuracy in a specific HIV population. So if you're looking here, you have your different, traditional risk score calculators. You have your Framingham score, the 5 and 10-year risk prediction model. You have the pooled cohort equations, the PCE, the 10-year one. That's the one that we all, use as our ASCVD risk calculator that we put in the MD Calc. And you also have the DAD, which pretty much is kind of a little bit more tailored towards HIV patients. It includes the traditional risk factors, but then also like the effects of ART therapy and other HIV-specific risk factors. And as you can see here, they all tend to underpredict cardiovascular disease events in HIV patients. So if we come over here to this larger study that looked at the most common risk calculator that we use, which is the ASCVD risk calculator for the PCE of 10 years, as you can see, the number of events were far greater than what was actually predicted. And I think that this is important because, as you can see here, the commonly used risk calculators do a pretty poor job at predicting ASCVD risk in HIV patients. And this observation has become the cornerstone argument for identifying HIV as a cardiovascular risk enhancer and using that information to guide our prevention and treatment strategies in HIV patients. In other words, for persons living with HIV, risk estimation requires more than just a formula. It requires clinical judgment, awareness of HIV-specific risk factors, and often a lower threshold to initiate therapy. So how does all of this happen? How does having HIV specifically lead to cardiovascular disease? Well, that's a loaded question, and I doubt we have the exact answer, but I'm happy to share some widely accepted hypotheses on how this may occur. So one of the common models in trying to understand this is the multi-hit model. So what this means is that in patients who have HIV, they have different risk factors than the general population that all contribute and work together to increase their cardiovascular disease risk. You have your viral risk factors, which include T cell depletion, immune activation. They also have intestinal permeability and gut translocation of bacteria, and they are often commonly in a pro-inflammatory state. Then you have your ART-related risk factors, which include early protease inhibitors that we talked about before. But even in modern day ART therapy, you still have some metabolic effects. And then thirdly, you have the non-viral risk factors. These are your traditional risk factors. These are things like hypertension, obesity, diabetes, and smoking, and hyperlipidemia. And once again, all these things together actually work together to kind of increase the cardiovascular disease risk in our HIV population. Now, looking more specifically at the viral related risk factors, I'm going to talk a little bit more about this in particular. So one of the central themes emerging from the literature is the role of chronic inflammation and immune activation. At the cellular and molecular level, HIV infection causes a strong inflammatory response, which leads to the release of cytokines that cause monocyte activation and recruitment to the endothelium. Then you also have adhesion molecules that are also stimulated, which then facilitates macrophages entering the endothelial layer. And there are specific HIV proteins that drive endothelial dysfunction that stimulate adhesion molecules and can impact ultimately the efflux of cholesterol in macrophages, contributing to foam cell formation. And it's important to note that even in virally suppressed individuals who are on ART, these patients still have persistent monocyte and macrophage activation. They also have elevated circulating inflammatory markers such as IL-6 and other signs of immune dysregulation. Imaging studies demonstrate increased arterial inflammation in persons living with HIV compared to those who are HIV negative. And these inflammatory and immunologic aberrations are likely what lead to the endothelial dysfunction, accelerated atherosclerosis, and more unstable rupture-prone plaques. Therefore, it is very important to realize that even in the absence of traditional risk factors, HIV-specific biology can itself increase cardiovascular disease risk. When we look at cardiovascular disease in people living with HIV, one of the most important concepts is that traditional cardiovascular risk factors are not just present in HIV patients, but they are more pronounced. They occur earlier and they tend to cluster more aggressively, than in HIV negative individuals. This amplifies their overall cardiovascular risk even before we factor in HIV specific mechanisms like chronic inflammation or immune activation. Let's talk about some of the major ones. First off, smoking, right? Smoking rates in persons living with HIV are roughly 2 to 3 times higher than in the general population, with many cohorts reporting rates up to 40 to 50%. And the impact is amplified, right? Because of chronic inflammation, because of chronic immune activation and endothelial dysfunction, the cardiovascular harm from smoking is actually greater in HIV positive patients than those who are HIV negative. Next, we'll talk about hypertension, for example. Persons living with HIV develop hypertension at younger ages, and the prevalence is significantly higher even after controlling for age, race, BMI, and socioeconomic factors. HIV also accelerates arterial stiffness, contributing to vascular aging and increased systolic pressures. And finally, comorbid conditions such as CKD and liver disease happen to be more prevalent in HIV patients, which add additional cardiometabolic burden. This here is a table that's pretty much for your own benefit and mine too. It's been a long time since I've had to memorize all the different types of antiretrovirals for HIV. But if you look to the left there, you have your ARV class. But the thing that I want you to take away are the different primary cardiovascular disease-related side effects that each drug class provides, right? But overall, it's important to understand that beyond inflammation, metabolic derangements, many of them influenced by ART, play a major role. Dyslipidemia, insulin resistance, and diabetes are all more common in persons living with HIV. And this may result from the ART medications themselves, but it also may result from inflammation, lipid dystrophy, or body composition changes. HIV and ART each also contribute to a distinct pattern of dyslipidemia. So look out for this, looking at your lab values for your patients. These patients often have low HDL, higher triglycerides, and with modern ART, especially the tenofovir elafenamide containing compounds, increases in LDL and non-HDL cholesterol. Importantly, these lipid abnormalities confer disproportionately higher ASCVD risk in persons with HIV than those who are HIV negative. Even our modern day ART has also been associated with metabolic syndrome and diabetes. With integrase inhibitors and TAF, we're seeing notable weight gain, particularly increased visceral fat, which drives insulin resistance and a higher incidence of diabetes at younger ages and often at lower BMIs. So metabolic syndrome is more common and progresses more rapidly in persons living with HIV. So you may be saying to yourself, Martin, that all sounds great, but what am I actually going to do with this information? How am I going to better serve this population with the information you provided? Well, I think the first step is a simple one, and it's likely the most impactful step, but it also could be the most challenging, and that's prevention through lifestyle modification. As with all patients, lifestyle remains the foundation for primary and secondary prevention. But in persons living with HIV, it may be even more impactful. The AHA emphasizes smoking cessation, healthy diet, cardiovascular exercise, and reduction in alcohol consumption. When I think of ways to counsel our patients on these things, I try to take a practical approach. For example, smoking cessation, right? When it comes to smoking, I actually think about my own mother and my mother-in-law, who both started smoking cigarettes in their teenage years. They both want to quit, and at baseline, they're very strong-willed individuals who are highly motivated and highly intelligent. However, I think when we're on the other side of the exam table from these patients, we take for granted just how addicting nicotine and tobacco can be, and we incorrectly pass judgment on these patients. And in turn, over time, we may document in our note, yes, we talked about smoking cessation, but the patient's not interested. And maybe after 2 or 3 more attempts, we stop pushing the issue. I think a more practical approach is to bring up smoking every visit and to not give up, even if you get a little bit of pushback from the patient. It doesn't have to be a long, drawn-out discussion each time, nor does it have to be awkward, but it could just be like a gentle reminder and letting them know that you're there for them should they change their mind. I think this approach could go a long way, especially in HIV population who tend to have higher rates of tobacco use. When we look at diet modification, or when I think about diet modification, I'm actually reminded of the time I was on a heart failure service at Emory Midtown, and I was at the Winship cafeteria getting one of those big, delicious chocolate chip cookies. And I get in line and I see standing in front of me, none other than the healthy diet patient coach himself, Dr. Sarescu. And then I get nervous and I jump out of the line and wait for him to leave before I ring up my things and eat my cookie, because I didn't want him to see me making bad dietary choices. Now, if I, a budding cardiologist, have trouble sticking to a clean diet, how much more difficult must it be for these patients, particularly in the HIV community, who often are from disadvantaged backgrounds? They live in food deserts sometimes, and they often have limited access to healthy dietary options. I think a practical approach I like to take for talking to patients about this particular topic is being relatable and being honest. I'll say something like, hey, I love Oreos myself, but I try to only indulge once a weekly instead of daily as a reward for sticking to a good diet the rest of the week. What this does is this breaks down the false notion that doctors have it all together and that we're perfect, and it provides an opportunity for honesty in our patients' struggles and striving for a healthier lifestyle. Now, when it comes to exercise, my approach with patients is very simple. Start small, be consistent. I tell them that if you go to the grocery store, park as far away as you can. And if you're able to do so, take the stairs whenever possible. Small goals like these are practical and attainable and can have significant results, especially in patients living with HIV. And lastly, when it comes to booze, I tell them, hey, we all like a good beer or a glass of wine every now and then, but it's important to keep it just that, every now and then. Overall, because the pathogenesis of cardiovascular disease in persons living with HIV is multifactorial, these simple behavioral interventions and practical discussions may yield substantial benefit, even beyond what we see in uninfected populations. The next strategy for managing these patients are lipid-lowering therapies, such as statins, right? So given the elevated risk, often underestimated by calculators, like we discussed, the presence of inflammation-driven atherosclerosis, even in patients with normal LDL levels, statin therapy has become a cornerstone in prevention for this reason. The American Heart Association recommends considering statins even when traditional LDL thresholds are not met. And since that time that recommendation was made, we have even more evidence to support the use of statins in HIV patients for primary prevention. And as some of you probably already know, we have the REPRIEVE trial, which was a large, multi-center, randomized, double-blind, international, placebo-controlled trial of roughly 7,800 patients who were living with HIV, ages 40 to 75, who were stable on ART, who had low to moderate ASCVD risk based on traditional calculators. Mind you, these patients wouldn't have been recommended to be started on a statin. And they were randomized to 4 milligrams of pitavastatin daily compared to the placebo group. And they followed these patients for a little over 5 years. And this is what they ultimately found. So as you can see here, in a pitavastatin group, there were lower events of MACE. There's about a 35% risk reduction in MACE. The cool thing about this is that even when they studied all their pre-specified subgroups, that this relationship held true, this finding held true. So irregardless of age, sex, region, their LDL baseline levels and their CD4 count is still reduced risk of MACE in these patients. The other thing that they found, which is no surprise to all of us cardiologists, is that it actually lowered their LDL. So there was about a 30% reduction in LDL from their baseline in a pitavastatin group. I think the other thing that's important is that this seemed to have conferred a decrease in their inflammatory markers, such as high sensitivity CRP, soluble CD14, and CD163, which actually supports the dual mechanism of statin therapy, which is that is LDL lowering, and that is also anti-inflammatory. The other thing that the study found was that initiating, pitavastatin in these patients was actually pretty safe, right? Yeah, sometimes, you had some patients who had some, who had a few more muscle symptoms like rhabdo or myalgias compared to placebo group, but it was still pretty low overall. If you look at here, you got about 39, almost 4,000 patients, and the number of events for that was only 91. And in the placebo group, it was only 53. So overall, it was still pretty low. Additionally, there was a small but significant increase in new onset diabetes in high BMI groups. And additionally, there was no clinically significant interactions with ART regimens, which proved that pitavastatin is one of the safer or safest statin therapies that we have. So Major conclusions from this trial is that pitavastatin significantly reduces ASCVD events. It also showed that HIV itself is a high-risk condition, which we kind of, talked about earlier. And also that statins should be used more broadly in HIV, consistent with the previous guidelines. Additionally, the REPRIEVE trial established that statins as first-line primary prevention therapy in persons living with HIV age 40 to 75 who are stable on ART. So that was pretty cool finding as well. All right, so more management strategies for lowering cardiovascular disease in persons living with HIV. I think there are some new pharmacologic considerations, such as immune modulators and anti-inflammatory drugs, actually. Because chronic inflammation and immune activation are central to HIV-associated cardiovascular disease, these represent a logical target. One promising study for this strategy of treatment comes from the CANTOS trial, which was a major multi-center, randomized, double-blind, placebo-controlled trial of 10,000 patients with prior myocardial infarction and high sensitivity CRP levels. And they studied these folks to see if targeted anti-inflammatory therapy using canakinumab, a monoclonal antibody against interleukin-1 beta, to see if it reduced MACE in patients with prior MI without altering lipid levels. And ultimately, the trial was designed to evaluate the hypothesis that inflammation, independent of LDL cholesterol, is a key driver of recurrent atherothrombosis. What they found, if you look to the left here, was that canakinumab was successful at lowering inflammation as measured by high sensitivity CRP levels. And it was able to do this independent of affecting the cholesterol levels. And to the right, you see that it also showed that at doses of 150 milligrams or greater, canakinumab significantly reduced the incidence of the primary endpoint, which was MACE, as well as reduced the incidence of the secondary endpoint, which is unstable angina leading to urgent revascularization. And that's what we have here in the right-hand corner. So as far as the conclusions that we draw away from this trial was that this actually provided the first definitive clinical proof that reducing inflammation alone without altering the lipids actually reduces recurrent cardiovascular events. It also demonstrated the role of the CRP inflammatory pathway, and it established inflammation as an independent and modifiable risk factor. And this is what basically paved the way for the other anti-inflammatory approaches, such as the use of colchicine in the COCOT and the LODOCO-2 trials. Although in this study they didn't use canakinumab in HIV patients, I think this trial is highly relevant to HIV cardiovascular disease patients because chronic inflammation is a hallmark of HIV, even when they are virally suppressed. So how should we integrate cardiovascular disease prevention and treatment into routine HIV care? I'm going to propose to you a practical approach that is adopted from the AHA recommendations and general cardiovascular disease prevention frameworks because I think it's reasonable. I think first, you have to optimize their HIV management, right? Viral suppression via ART remains the foundation of care. And we know that sustained suppression actually reduces cardiovascular disease risk. Next, we should be doing annual ASCVD risk assessments on these patients who are age 40 to 75 or even younger, depending on their risk. And we should use risk calculators such as the pooled cohort equations or an equivalent. However, we shouldn't just use those alone. We should also use risk enhancers, especially HIV-related risk enhancers, to guide decision-making on statin initiation, even when the calculated 10-year risk seems to be modest, okay? And then once they're on statins, or even if they're not, we should still be doing periodic lipid screening. For people who are on ART, it's pretty good to get a baseline lipid panel, and then to repeat it 3 to 6 months after viral suppression, and then to repeat it annually, especially in those who are 40 years old or older or who are on statins. Next, we should be collaborating in a multidisciplinary way. We should be pulling together our HIV providers, our infectious disease colleagues, the primary care doctors, and cardiologists, and we should be trying to integrate preventive cardiology into HIV clinics, which I haven't seen, done the best. And then we should also be monitoring carefully for ART and statin or other drug-drug interactions and then adjust the therapy accordingly. I think overall, this integrated model ensures that cardiovascular prevention becomes a core element of long-term HIV care and not just an afterthought. Okay, so now that we reviewed all this wonderful information, let's recap some of the major takeaways from what we've learned today. Number one, people living with HIV have higher ASCVD risk than those who don't have HIV. I think that's pretty clear now. Two, traditional cardiovascular risk factors are more pronounced in HIV, such as smoking and hypertension and different things like that we talked about. Standard ASCVD risk calculators actually underpredict risk in HIV. HIV, given its distinct pathophysiology, should be treated as a cardiovascular risk-enhancing condition.
Good morning.
ARB regimens influence cardiometabolic risk, which we've shown, and statins actually reduce ASCVD risk in HIV. And a reprieve trial is practice changing for us for this reason. And chronic inflammation and immune activation remain central drivers of ASCVD and HIV, and immune modulation actually may be the future of care for this population. And lastly, two heads are better than one. Multidisciplinary care actually improves outcomes. So now that we, have been effectively educated on this topic, let's go back and take a look at the answers for the case-based questions that we asked at the start of the presentation. Okay, so to remind you, we had this 55-year-old gentleman who was on long-term integrase inhibitor therapy. He had some cardiovascular disease risk factors, okay? And he also has HIV, which is a risk enhancer, okay? And we asked about the best next step. Most of y'all actually got this right, so I'm very, very, very proud of you all. The correct answer is A. So the best answer is to start moderate intensity statin immediately. You can talk about plus or minus coronary artery calcium scoring, like in particularly if they are uneasy about starting statins or they want a little bit more evidence. And then as always, you want to reinforce lifestyle interventions. So you guys did a good job with that one. For case two, that's when we had the 50-year-old woman who presented after an NSTEMI. This one actually had the most varied answer response. Nobody was pretty much on the same page when it kind of came to this. And we said, which lipid lowering strategy is safest and guideline aligned? And so the correct answer is actually B, right? We know that, pitavastatin is actually pretty safe and does not have the same amount of CYP3A4 inhibition, which then interacts with the protease inhibitors and different drugs. So of all these answers, answer B is the most correct. And then when it came to case three, we had the 57-year-old gentleman who was virally suppressed and presented with exertional chest pain. And you guys are too smart for me to stoop, and you were right. The correct answer is A. It was likely due to microvascular ischemia. And it was important to optimize these risk factors and consider starting a statin therapy. And it's important to note that HIV-related chronic inflammation can cause coronary microvascular dysfunction. But you guys picked up on that, so you all did a good job. That concludes my talk. I thank you all for listening. Here are my references, and I'm open for any questions.
Thanks, Martin, for that really thorough talk. I'm curious because from the fellows, really, how often are you seeing HIV patients in your clinics at Grady or the VA?
Hey, it's Sophie. I have Grady Clinic. I have a few, honestly, most of them like well controlled, like a handful maybe. And to be honest, I haven't really like considered it as an additional risk factor or risk enhancer. I've kind of just treated them the same. So this is really helpful.
Hey, Martin, great talk. Just to plug, there's a number of folks that are actually looking into this as a research interest. So if any fellows have an interest in HIV and coronary disease as a legitimate research interest, there's been some collaboration with cardiology and infectious diseases over the years. We did a cath lab-based angiographic retrospective review 5 years ago, but since then, some of these folks have done some interesting stuff. So if anyone's interested, feel free to reach out. We can get you plugged in with the right people.
Martin, thank you. This is Mahmoud. To answer Dr. Coley's question, I do have few in my heart failure clinic, a few patients with HIV, and I'm glad that Sophie brought this up because it is really a strong risk enhancer for not just coronary disease, but all this for the whole spectrum of cardiovascular disease, especially heart failure. So good job, Martin, on bringing this topic up.
All right. Are there any more questions or comments?
I was going to say, if there's no more questions or comments, we can wrap it up a little bit early. Everyone have a great weekend, and we'll see you next week.
The preceding program is copyrighted by Emory University.